Thank you very much, Puneet, and good evening, friends, ladies and gentlemen. I'm glad that we are on the second session of the masterclass, and this time the case presenter is again Dr. Shrinath Mashale from PGI Chandigarh, and the examiner is a doyen in the nephrology field, the teacher of teachers, a brilliant academician. He has been my teacher also, loved by most of us, and people want to listen to him whenever he is talking, is Professor Vinay Sakhuja. I think he is the examiner today. And the discussant is Professor Pankaj Malhotra. Many of you may not be knowing him. He is HOD Clinical Hematology and Medical Oncology at PGIMR Chandigarh. He's a brilliant person who had done long back fellowship at Mayo Clinic Rochester. That was in 2015. He's a member organizing commission of 2117 2017 International Myeloma Group. He's a founder president of Indian Myeloma Academic Group, and he has got a principal investigator of huge number of research projects. If I am not mistaken, over 37 research projects. He is a huge principal investigator. So I think it will be pleasure listening to him. And Professor Kher, sir, your comments, and then we start, sir.
I think it's a pleasure to have both Vinay and Dr. Prashant also to be amongst us today. And actually, my romance with multiple myeloma started way back when Vinay was the editor, and I submitted uh, some number of patients in early 90s. And Vinay called me and told me that how come you are seeing so many multiple myelomas in your unit? You probably are overdiagnosing them. And then soon, few years later, I hope he remembers it. He called me back and he says, yes, we have also started looking for them, and now we're finding them more and more of these. And that has been the history of multiple myeloma. It remains, even though you may have a high index of suspicion, but it still sort of beats you away and remains hidden for some period of time. So you will have to think about it. And then one of the ex-prime ministers who happened to have the same disease and lived on dialysis, and I got to sort of read more about it from Bob Kyle, whom I met when he was in Mayo, and then uh, Vincent Rajkumar and all, who have been sort of pioneers in the treatment, as well as all the things that have happened and progressed in multiple myeloma over the years have come from Mayo Clinic, and it's such a pleasure to have amongst us the professor from PGI itself and Dr. Prashant. So it would be such a pleasure to have. So let's start without
Yeah,
any
I
further
forgot to
ado,
mention also, sir, that today's expert is
Dr.
again a very
Ellen
academic,
Almeida.
thorough academician and a brilliant nephrologist from PD Hinduja. He's an ex-professor at KEM, Professor Ellen Almeida. Yeah,
Yes.
over to the student. Can we have Srinath?
Sir, good evening, everyone.
Yes.
Yes, please go ahead. Yes.
Uh, sir, can you share the slides? Puneet, sir.
Good evening. Yes. Your face is getting partly cut. Yeah, just a little bit higher. Yeah, yeah. That's better now. That's better.
Puneet, sir.
Yeah, this is fine.
Yes. Yes.
Yes. Good evening, everyone. Today I am presenting a case of, next slide, a case of 67-year-old female, PK. She is housewife, educated up to 10th class, informant being daughter of the patient, and history is reliable. Next slide. She came with complaints of backache since last 3 months, easy fatigability since last 3 months, shortness of breath since last 2 months. Next slide. Coming to the history of presenting illness, history dates back to January 2025. Patient came to do OPD in April. There was a backache which was insidious in onset, gradually progressing, dull looking lower backache which was non-radiating, which increases with movement and partially relieved with rest and oral analgesics. It was not associated with any shooting pain or numbness. There has been normal bladder and bowel control, and there is no history of fall or trauma. There was no history of any fever or weight loss. Next slide. History of fatigability and shortness of breath for on exertion for last 3 months, which was also insidious. Initially, the shortness of breath was during climbing 3 flights of stairs, now progressively worsening on walking and performing day-to-day activities. It relieved on rest, and it was not associated with chest pain, sweating, PND, or orthopnea. Negative history. There is no history of any cola-colored urine, hematuria, hemoptysis, epistaxis. There was no history of any dysuria, loin pain, abdominal pain, nocturia, polyuria, urgency frequency, or any CTD features like oral ulcers, rash, hair fall, photosensitivity. There was no bleeding manifestation, and there was no weight loss. For this, she underwent blood workup, and she was being told that she was having anemia and deranged renal function, for which she was initiated on hemodialysis twice a week via right IJV line from January 2025 from outside hospital. And she doesn't remember her interdialectic weight gain, while her urine output was around 1 liter. Patient does not remember any specific investigations were done at the same time, and later she continued having loss of appetite, nausea, generalized weakness, for which she came for consultation in the OPD. Next slide. In OPD, patient underwent blood investigation and bone marrow examination. Patient received saline infusion. She was being told that there was increasing calcium for which saline was infused for 2 days. After which she was told that she was having blood cancer and chemotherapy should be started. She was started on chemotherapy, and dose and nature of chemotherapy patient is unaware of. Later, because of repeated admissions for pneumonia and urinary tract infection, chemotherapy was stopped around after 1 month, and currently patient is on hemodialysis. Past history: patient is a known case of diabetic since last 3 years on oral hypoglycemic agents. There was no history suggest of any diabetes-related micro or macrovascular complications, and as per patient's attendant, her diabetes was in control. Personal history: patient's sleep was normal. There is reduced appetite. Bladder bowel was normal, and patient denies any addiction. Family history: there was no family history suggest of any renal disease like renal stone disease. She denies any history of diabetes in parents and siblings. Menstrual history: she achieved menarche at 14 years, normal menstrual cycles, and now postmenopausal since last 15 years. Obstetric history, which was within normal limit, there was no significant obstetric history. Coming to the general examination, patient examined. She was sitting comfortably, conscious oriented. Pulse was 100 per minute, regular, normal volume. Blood pressure was 140 by 80 millimeters of mercury, right arm supine position, and while in standing, it was 130 by 84 millimeters of mercury. There was pallor present, no lymphadenopathy, clubbing, icterus, or edema. Right IJV non-tunnel catheter was in situ. On spine examination, there was no any bony tenderness or no gibbous swelling. Coming to systemic examination, cardiovascular examination, there was no murmur, no S3 gallop present. Respiratory system, which was normal vesicular bed sound, clear. On per abdominal examination, no organomegaly noted. While CNS, fundus was within normal limit, power was 5 by 5 in all 4 limbs, and reflexes were normal. Some research. My patient, 67-year-old female with relatively short history of diabetes, came with complaining of backache, easy fatigability since last 3 months, and she developed renal failure, requiring dialysis twice weekly by right IJV non-tunnel catheter since January 2025. Now presented with worsening of her symptoms. My syndromic diagnosis is CKD 5 on hemodialysis. Likely etiology is paraprotein-related renal injury, and possibility of diabetic nephropathy. I would like to keep, sir.
Okay, don't go on to the investigations just as yet. You can hold on there. Yeah, keep that slide on. So you have a 67-year-old female a lady with a history of diabetes of about 3 years duration,
Yes, sir.
and now she has come to you with apparently in CKD, and she's already dialysis dependent for the last 2 months or so. That is the time when she first contacted us for consultation. So she was already on dialysis at that time. So, what is the differential diagnosis that you're considering? Can you expand on that?
Sir, coming to the differentials, sir, being diabetic since last 3 years, and there was history like that there was no any diabetic related complications, and patient was telling that her sugars moreover was within normal range. So I have kept the possibility of diabetic nephropathy, but the likelihood will be lesser in this case. While coming to the paraprotein related renal injury, so there is she is elderly female with complaint with type B symptoms like backache, generalized weakness, and easy fatigability since last 3 months. And cause of renal dysfunction was also not clear, sir. And there was persistent anemia as also. So I would like to keep sir paraprotein related injury first than diabetes.
Okay. Yeah. The diabetes is only of 3 years duration.
Yes,
So
sir.
that is usually not enough to cause overt nephropathy, leave alone going into CKD5. And she doesn't have any diabetic retinopathy that was excluded by a careful fundus examination.
Yes, sir.
So even that is ruled out. So therefore, diabetic nephropathy, although that the possibility can never be totally ruled out,
Yes, sir.
it seems less likely.
Yes, sir.
And so one does need to consider other possibilities. And in an elderly individual with backache, with anemia, obviously, yes, as you said, paraprotein related renal injury
Yes, sir.
should come into consideration, should be an important possibility that you should bear in mind. In an elderly individual in this age group, what other condition should you think of
Uh,
as a cause of CKD?
Sir, ANCA vasculitis can be a possibility, sir. Could
Yeah, ANCA vasculitis, all right. It's a possibility in the elderly, more common. All right. Anything else which again is more likely in this age group or in patients even older than this?
Older
Um,
people, vascular diseases, what else?
yeah, yeah, exactly, exactly.
related.
Why don't you think on those lines? Yeah.
Have you heard of azotemic renovascular disease?
No, sir.
No.
Okay.
Supposing a patient develops severe atheroma of the abdominal aorta, and the atheroma also involves the renal arteries,
Yes,
both the renal arteries, maybe more on one side, maybe less on the other side. So, can you get CKD as a consequence of that?
yes, sir.
Isn't it?
Yes, sir.
And this is the age group
Hmm.
in which you would get that kind of problem also in the late 60s, 70s, 80s. So that is the age group where you should consider it. So that's another important differential diagnosis, particularly in the elderly. That's not something you will suspect it in a 40-year-old or a 50-year-old, right? So that's another, besides paraprotein related injury, this is another possibility that you should bear in mind in the elderly,
Okay, sir.
right? If you have bilateral renal artery stenosis due to atheroma, so if there is a significant degree of stenosis, you could get CKD. This is the possibility that we are talking of. Of course, Such patients may often be hypertensive as well. In this patient, there was no hypertension. She is not requiring any antihypertensive therapy either,
Yes, sir.
right? So that's a relative point, but that doesn't totally exclude that possibility.
Yes, sir.
Okay. So that is the other important
Differential.
uh, differential diagnosis that you should consider.
Okay, sir.
Um, in a patient with CKD, are there any pointers which will more strongly suggest a paraprotein related injury?
Yes, sir. Even in spite of giving say erythropoietin, if patient is having persistent anemia, even in spite of correcting iron and supplementing with erythropoietin, there will be some persistent anemia. Other than that, sir, there will be weight loss, which will be sir, which will be present in paraproteinemia related renal injury, sir. And
Okay.
just
Uh,
like hypercalcemia can be there, sir.
yeah, yes. Hypercalcemia is another important clue that one should look for, which was also present initially in this patient, right?
Yes,
Uh, it's not just the persistence of anemia or the resistance to erythropoietin, it is anemia out of proportion to the degree of
renal.
renal insufficiency. That is what you should look for, right? And yet other pointer could be hyperglobulinemia,
Yes, sir.
right? If the serum proteins show you hyperglobulinemia, that's another indicator that you might need to look for monoclonal gammopathy. So these are some of the indicators. And of course, you think of this possibility in the elderly. But what about supposing this patient was only 45 years old or 40 years old?
Sir, by incidence, sir, the possibility is still there, sir. But in less than 50 years, sir, 10% of patients may present with paraprotein, multiple myeloma, and in less than 40, sir, around 2% patients may present with this, sir.
Yeah. So I especially wanted to emphasize that because generally people tend to think, that myeloma is a disease of the elderly. Monoclonal gammopathies are only a disease of the elderly. And it is true that the median age of these disorders is around 65 years. But as you said correctly, a small number, 2%, may be even below the age of 40 years. And 15% of them are below the age of 60 years.
Yes, sir.
So, therefore, even just because a patient is relatively younger, don't exclude this possibility. Don't ignore this possibility. That's an important caution that I would like to emphasize. Right?
Yes, sir.
Okay. So, uh, in a diabetic, what are the features which would tend to suggest non-diabetic renal disease rather than diabetic nephropathy? For instance, in this patient, we already said that the diabetes was only of 3 years duration. There was no retinopathy,
Yes, sir.
right? So those are two features which go against the diagnosis of diabetic nephropathy. What else would you be looking for?
Sir, rapid fall in GFR in if patient is diabetic kidney disease having, and if there is
Yes.
in GFR, we have to look for any other causes like non-diabetic kidney disease, presence of active urinary sediments. We should look for other causes also, sir.
Yes, active urinary sediment means RBCs in the urine.
Yes, sir.
So microscopic or gross hematuria, a
Yes,
rapid rise in the serum creatinine or a fall in the GFR. Yes.
yes, sir.
Anything else?
Sir, proteinuria, which if it is out
Yeah.
of function, then we
Yeah.
can consider other causes, sir.
Yeah, but you do expect albuminuria or proteinuria in patients with diabetic nephropathy, isn't it?
Yes, sir.
So the absence of proteinuria or absence of albuminuria would be a point against diabetic nephropathy,
Yes, sir.
right? If there is CKD without. And what happens to the kidney sizes in diabetic nephropathy?
It is more over, sir, normal or increased size, sir.
Yeah, usually the kidneys, when the patient is just reaching end stage, the kidneys are not contracted. So if you have contracted or asymmetrical kidneys, and always think of
Non.
some other possibility like non-diabetic renal disease, right? So those are some of the, and then if you have any hypocomplementemia, that again would be a
Good
point
understand.
against diabetic kidney disease. So those are some of the important things to bear in mind, which would go against the possibility of diabetic renal disease,
Yes, sir.
right? Okay. So when you, with these possibilities in mind, what investigations would you like to do before we go on to what exactly was done in this patient? What would you plan for this patient?
Sir, first I would like to see, sir, CBC. Look for hemoglobin, ESR, and if there is other than, sir, that in biochemistry, I would like to see, sir, serum creatinine, total protein albumin, followed by, sir,
Yes.
any total bilirubin, direct bilirubin, and apart from that, sir, calcium I would like to see, sir.
Yes, yes. Okay.
And
So the calcium, you've already mentioned that hypercalcemia can be a feature of myeloma
yes, sir.
or monoclonal gammopathies. How often do you get hypercalcemia in paraprotein related disease?
Uh, So, hypercalcemia paraprotein related is, it is basically paraprotein independent most likely, and it is seen in, sir, around 25%, 20 to 25% of cases, sir.
Yeah, maybe
50%.
maybe anywhere from 10 to 15%, maybe a little less than what you've mentioned. So, but yes, and since we are talking about hypercalcemia, why do these patients get hypercalcemia?
Sir, because of, sir, myeloma cells, which will activate, sir, which will stimulate rank ligand, which will binds to rank and leads to increase in activation of osteoclast, sir. This will leads to osteoporosis and loss of bones, sir, leading to hypercalcemia.
Right, right. So yes, so these are so-called osteoclast activating factors produced by the plasma cells, and these cause bone resorption
Yes, sir.
and therefore result in hypercalcemia, right? So yes, that's good. So okay, so you like to look at the serum calcium. What else? What next would you like to see?
Sir, vitamin D, parathyroid hormone, followed by, sir, urine routine I would like to see, sir. If
Urine routine, yes. Okay, yeah. So because there is hypercalcemia, yes. So the looking at the vitamin D status and the parathyroid hormone is important,
yes, sir.
because they also might have a relationship to the hypercalcemia that you have in this patient.
Yes, sir.
So that is certainly important. Okay, what else?
The urine
Right.
routine,
Urine routine examination. Okay, in the urine, what exactly are you looking for?
sir, both, sir, protein and albumin. And if there is any after that, sir, 24-hour urine protein quantification also important, sir. And presence of any BJ protein is there or not.
Okay, so do you want to look for you want a 24-hour urine protein, or do you want albumin creatinine ratio? Which one do you prefer?
Albumin I would like to see, sir. Basically, I would
Albumin.
both, sir, because 24-hour urine protein I would like to see both protein and albumin also, sir.
Why do you want to see both?
Sir, for light chain cast, if there is a protein, there will be, sir, presence of, sir, tubular proteinuria. Because of that, there would be, sir, protein. And if there is along with multiple myeloma, if there is associated amyloidosis, then albumin, because of glomerular injury, there will be, sir, albuminuria, sir. So because of that, I would like to see both, sir.
Yeah, so that's a very important point that you have made. So this is one condition where it is important to look for both the PCR and the ACR,
Yes,
right? So you want a protein creatinine ratio also, you want a albumin creatinine ratio also, because in some patients you may have an abnormal PCR and a normal ACR,
Yes, sir.
and in some patients you may have both abnormal.
Yes, sir.
So this is not a situation which applies to most other glomerular disorders where only the ACR is abnormal,
Yes, sir.
right?
Yes, sir.
Because the major protein in the urine is albumin in those. Whereas here, the protein in the urine could be light chains, or could be albumin, or could be both,
Yes, sir.
depending on the type of kidney involvement that you have. So
Yes, sir.
that's a very important point for all the students to note, that looking at both the PCR and the ACR separately is important in this group of patients. And how would you look for Benz-Jones protein?
Sir, ideally it should be done with sulfosalicylic acid test, sir.
Yes.
Sir, in that, sir, we have to take the urine and add sulfosalicylic acid. Because of, sir, presence of paraprotein or light protein, it will, sir, depending on temperature, we have to look, sir. If Vijay protein get precipitated at 56 degrees Celsius, sir, and upon, sir, heating up to 100 degrees Celsius, it will, sir, dissolve, sir. So it will confirm that there is a presence of Benzoin protein in the urine, sir.
Yeah, but you mixed up the sulfosalicylic acid and the heat test. The sulfosalicylic acid test is separate. You don't need to heat the urine in that. The heat test is the old way of looking for Benz-Jones protein, right? Nowadays, you would do electrophoresis of the urine if you want to look for it,
Yes,
or
sir.
you can do the sulfosalicylic acid test. So the heat test, when you do the heat test, then that those temperatures apply which you mentioned.
Yes,
All
sir.
right. Right. So if you do a dipstick test, what would happen?
Sir, there can be, sir, dipstick can be negative, normal, sir, because
Yeah, it is not sensitive to light chains. It is only sensitive to albumin,
yes, sir.
and therefore the dipstick will be negative if you have only light chains in the urine,
Yes, sir.
and it will miss that abnormality.
Yes, sir.
So that's another important point to note, because if you've just done a routine urine examination, the report will show negativity,
Yes, sir.
right? And
Yes,
it's only when you do the 24-hour urine protein estimation, or do you do the urine protein electrophoresis, that you will be able to detect the abnormality.
yes, sir.
Right. So these are some of the investigations that you wanted. All right. What else do you want beyond this?
Well, serum protein electrophoresis and
Okay.
fixation and SFLC also, sir.
SFLC. Okay. Now, coming to these three important tests, right? So, do you want only one of them? You want two of them? You want all three of them? And why? Tell us the answer
Sir, because
to each.
sensitivity of these tests, sir, if you do, sir, only serum protein electrophoresis, sensitivity, sir, around yeah, 88%, sir. And followed by if we do both protein electrophoresis along with immunofixation, sensitivity increases up to, sir, 92 to 94. While doing three, sir, around 98 to 99% sensitivity is there, sir. So we will the chances of missing of myeloma with doing three, sir, less. So I would like to I would like to do, sir, three both all three tests, sir.
All three tests. Yeah, that would be the ideal situation.
Yes, sir.
But of course, you should remember that the all these tests are quite expensive.
Yes, sir.
So that is why it becomes difficult to straight away do all three in every patient. So, so it's possible that you may, to reduce the expenditure, you may do two at a time,
Yes, sir.
and then if there's something there in those two tests, then you may go for the third one to
Yes,
complete the workup.
yes, sir.
So you could reduce the expenditure by doing that. But yes, you're right about the sensitivity. The serum protein electrophoresis is the cheapest of these three tests. but it is also the least sensitive. So it can miss up to 20% of patients with a monoclonal gammopathy.
Yes, sir.
And what exactly does the serum protein electrophoresis tell you? What information does it give you if it is abnormal?
So it will tell us the amount of M protein, sir. Quantification.
Yes, yes. So it tells you, it quantitates the M protein,
Yes, sir.
right? And what is that? Why is that quantitation important?
Sir, because after this, sir, we can classify if that paraprotein related injuries, it is a younger smoldering myeloma, or if it is a multiple myeloma, we can classify, sir.
Classify, yes. So the quantitation is very important, and that is given by the serum protein electrophoresis.
Yes,
What is the information that you get from the immunofixation?
sir, type of M protein, sir. Type of M protein, like if it is a heavy chain along with the light chain, we can get to know after doing immunofixation.
Not only that, you also get the type of
Like,
immunoglobulin.
yes, sir. Heavy and light both, sir.
Yeah, so you get what are the types of myeloma? How do you classify them?
Uh, Sir, it's depending on sir immunoglobulin. First, sir, if it is a immunoglobulin IgG related, IgA related, along with sir light chain, like if it's kappa restricted or lambda restricted, sir.
Yes, yes. So IgG is the commonest type of myeloma. Then comes IgA and light chain myelomas,
Yes, sir.
right? And the rarest are the IgD and IgE myelomas. So that is the hierarchy, right?
Yes,
So the immunofixation tells you the immunoglobulin type and the light chain type
yes, sir.
that you're getting, or heavy chain if you're getting rarely heavy chains, right? So, but it doesn't quantitate.
Yes, sir.
So, although it's more sensitive than serum protein electrophoresis, it doesn't quantitate,
Yes, sir.
right? That's the deficiency.
Yes, sir.
And finally, what does the SFLC tell you?
Sir, SFLC will tell us the amount of the light chain ratio, like kappa, how much it is in blood, and lambda ratios.
Yeah. So, whether they are in normal quantity or whether one of them is increased out of proportion to the other. So, the ratio of kappa to lambda,
Is this change, sir?
that will change
Yes, sir.
whichever way it changes. And so, that is what will be the finding there in case you have a positive finding.
Yes,
And you, what do you have to bear in mind when you are interpreting the ratio?
sir, we have to look for if there is any renal dysfunction, sir, because normal ratio we consider 0.26 to 1.65, but in
Yes.
renal dysfunction the ratio will change, sir. It is 0.3 to 3.1, sir.
Yeah. So if the patient is having CKD, obviously this ratio will change. The cutoffs will change, and you need to be aware, as you already mentioned.
Yes, sir.
Okay. So these are the important uh, conclusions as far as these three investigations are concerned,
Yes, sir.
which all of you need to be aware of, that these will really tell you what kind of monoclonal gammopathy you're dealing with, and how you need to manage these patients.
Sir.
Okay, so now we can go further to the investigations that were done in this patient
Yes, sir.
before we carry the discussion forward.
Puneet, sir.
Yes.
Lab reports, patient's HB was 8, albumin was 3.3, urine routine suggestive of 3 plus protein. Microscopy, there was no abnormality detected. 24-hour urine protein and urine ACR was not available. And ultrasound abdomen, right kidney was 9.2 centimeter, left kidney was 8.5 centimeter. HbA1c was 7%. Next slide. Serum calcium was 11.2 milligram per deciliter. PTH was 409 picogram. Vitamin D was 82 nanomole. Serum M protein suggestive of presence of M band. Quantification, it was around 1.2 gram per deciliter. while immunofixation suggests presence of IgG kappa, while SFLC ratio was around 102. Further
Yeah,
skeletal.
so yeah, we can just stop here. Just go back. Yeah. So this patient did have hypercalcemia, but the hypercalcemia was not a persistent one. It did not require any specific therapy except for
Yes,
IV fluids for the initial day or two, and it responded very rapidly in this patient,
yes, sir.
right? So it was not a difficult problem to treat.
Yes, sir.
The PTH was elevated, so most probably this is part of secondary hyperparathyroidism
Yes,
as
sir.
part of as a consequence of CKD. The vitamin D levels were
Good.
slightly towards the upper limit of normal,
Yes, sir.
and yes, so you have the quantification of the M protein, you have IgG kappa, and you have a free light chain ratio,
Yes, sir.
kappa to lambda ratio, which is more than 100 is to 1.
Yes, sir.
The involved to the uninvolved light chain ratio is more than 100,
Yes,
just
sir.
over 100. All right.
Yes, sir.
So the all these three criteria are being fulfilled in this patient that we just discussed a short while ago.
Yes, sir.
We go on to the next slide.
So, on skeletal survey, sir, X-ray skull and X-ray spine, there was no lytic lesion, while NCCT head, there was multiple lytic lesions in the skull were present. And bone marrow aspiration and biopsy suggest of 55 to 60% of plasma cells, and FISH cytogenetics suggest of 13q deletion.
Okay.
Uh, so my final diagnosis is chronic kidney disease 5 on maintenance hemodialysis via right IJV. Basic disease paraproteinemia related renal dysfunction, likely light chain cast nephropathy with CRAF features. Status post first cycle of chemotherapy, cyborrhea in case of type 2 diabetes.
Okay. Okay. Right. Yeah. Do you have the CT pictures also?
No, sir, I am
No,
not able
you don't.
to. Sir.
Oh, you couldn't load them. Okay, doesn't matter. Well, the interesting thing was that the X-ray of the skull was not showing any lesions. However, an NCCT of the head was done because at a later stage this patient had an altered sensorium. So it
Yes,
was mainly done for to look at the brain. We didn't find any acute lesions in the brain, but
yes, sir.
the NCCT of the head picked up small lytic lesions in the skull bone.
Yes, sir.
So that did show up. The spine showed only a reduced, I might mention here, since it's not on the slide, there was a reduced height of the L1 vertebra, but there were no lytic lesions seen,
Yes, sir.
right? So, and there was osteoporosis. So those were the findings. So this is you have any other investigations? That's all.
Yes, sir.
That's
Two,
all. Okay.
two clarification, if we can ask the student.
Yes. Yes.
One was when the X-ray is not showing, which is very common in almost 30 to 50% X-ray may be normal. Which one you will prefer, CT or MRI, if you have to pick up lytic lesion? And second comment I want is that whether you will like to do kidney biopsy or not.
So
Yes.
regarding kidney biopsy, sir, sir, basically there was 50 to 60% plasma cells are present, and SFPC ratio is also high. The likely possibility of light chain cast nephropathy is high, but for treatment part, we can consider for of doing kidney biopsy, sir. To if matlab this much of light chain is present, but the evidence for matlab if in kidney biopsy there is a light chain cast confirmed, we can go with other modalities of treatment like high cutoff dialysis and plasma exchange. But the evidence of those are, sir.
So should the message go that the biopsy is not required if SFLC ratio is over 100?
Yes, sir, we can avoid biopsy, sir.
And between CT and MRI?
Sir, MRI, sir, in MRI we have to go for cadolinium, sir, and in CT in
No,
renal.
why? CT, MRI plain? It's not a contrast MRI. If you're doing a plain MRI, you don't require that
Yes, sir.
gadolinium.
Sir, yeah,
Yeah, MRI
yes, sir.
is generally preferred.
Yeah.
Yes. If you're looking for bone lesions, MRI is more sensitive than a CT scan.
Yes, sir.
There's no doubt about that. I'll come to the slim crab criteria also.
Yes, sir.
So MRI is preferred, and the other alternative, of course, if you're doing a PET CT, then that also can pick up lesions.
Okay.
So in this, it was actually the neurologist who was consulted because of the altered sensorium at one stage, and they advised the NCCT. And on the NCCT, this lesion was just incidentally picked up, and we were informed by the radiologist. So on the other skeletal survey, we did not find any bone lesions, but we have not done an MRI,
Srinath,
and we have also not done a PET CT.
why a person can have altered sensorium in a setting of multiple myeloma?
Yes, that's an important question that Dr. Varma has raised.
Sir, so for altered sensorium, we have to look for there are multiple causes, sir. One of which being, sir, type of myeloma, sir. Paraprotein. If it is a IgM related, then there can be hyperviscosity, which can lead to, sir, altered sensorium. And sir, less likely, sir, plasmacytoma won't be, sir, within skull. So likely hyperviscosity is most common. One of the common cause for altered sensorium. Second, sir, myeloma cell tend to produce, sir, ammonia, so which can also leads to altered sensorium, but the incidence is rare, sir.
What about hypercalcemia?
Yeah, the commonest one is hypercalcemia. If you are having severe hypercalcemia, which is 14 and above,
Yes, sir.
possibly you might have altered sensorium.
Yes, sir.
Yeah,
There may be
yeah,
other things,
yeah.
constipation and whatever, but you might have altered sensorium.
Yes,
And
sir.
that is a requirement of fast reducing the. And how do you reduce the calcium? If it was 14 or 15,
Sir, if it is producing symptoms, sir, I will directly go for dialysis, sir. If patient is don't having any such kind of symptoms, calcium is around 12 to 14, sir, I will go with hydration followed by calcitonin and denosumab, sir.
how fast calcitonin will act?
Uh,
And yeah, if you are having high calcium,
yes,
altered sensorium, now first, what is the first thing you will give? Hydration is all right, followed by
sir, if it is altered, sir, then I will directly go for dialysis, sir.
agreed, that's all right. But if not altered sensorium, but calcium is 14, 15.
Yes, sir. Yes, sir, if patient is affording, I will start with denosumab, and if not possibility, sir, then calcitonin I would like to prefer. But sir,
You see, the question is calcitonin is acting fast.
yes, sir.
Initially, you will have to give calcitonin
Yes, sir.
because calcitonin is acting in hours.
Yes, sir.
When you are giving alendronate, they are going to act in days, 2 to 4 days. So first action will be hydration, calcitonin, and then comes the action will start of alendronates.
Yes, sir.
And emergency, yes, dialysis is a modality.
Yes. So that's an important point. The hypercalcemia as a cause of altered sensorium and how to manage hypercalcemia in this setting. These are very important issues that all of you need to be aware of. Now, um, patients with multiple myeloma, uh, do they straight away develop multiple myeloma, or is it preceded by something else, sometimes at least?
Yes, sir. It is called, sir, myeloma continuum. First, there will be, sir,
Yes.
monoclonal gammopathy of undetermined significance, followed by
Yes.
overt myeloma, and later stage, sir, they progress to multiple myeloma.
Overt myeloma. Yes. So there is a disease continuum.
Yes, sir.
So, so patients may pass through three different phases. MGUS, which is a phase which can last several years. That's an important also point to remember. MGUS doesn't progress very rapidly to myeloma. It can last 10 to 15 years, and the patient may never progress also,
Yes, sir.
right, during his lifetime. However, when the next stage comes, smoldering myeloma, that can progress much more rapidly to overt myeloma.
Yes, sir.
And now people think that even you can start treatment at the stage of smoldering myeloma. I won't go into that. I'll leave that for Dr. Pankaj to take up later in the course of the evening. Uh, and what separates MGUS from smoldering disease?
Sir, amount of M protein, sir. If it is less than 3, then it is MGUS, sir, and presence of plasma cells, sir. If it is less than 10%, which is seen in MGUS, while in smoldering myeloma, there will be amount of M protein will be more than 3 gram, and plasma cells will be 10 to 60%, sir.
Right, good. That's the important differentiation. And we talked about the urine examination, but just one small point that I missed out earlier. What when you have Bence-Jones proteinuria, what type of proteinuria is this called?
Sir, overflow tubular proteinuria, sir.
Yeah, it's don't use the term tubular, use the term overflow.
Yes, sir.
Right, that's the type of proteinuria that it is called, because the word overflow is used because the capacity of the proximal tubule, which deals with these light chains normally, which catabolizes them, is overwhelmed,
Yes, sir.
and that is why they get excreted in the urine. So that's why it's called overflow proteinuria.
Yes, sir.
And
Srinath,
the,
how much light chains can be absorbed or metabolized by proximal tubule? Up to 500 milligram a day. If it is exceeding that, then it's overflow.
Okay, sir.
yes, and yes, one other important point with regard to that: what is the molecular weight of these light chains?
Sir, for Kappa, sir, it is around 22 kilodalton, and lambda,
Yes.
likely it is many of the times it is dimer, so around 44 kilodalton is the around size, sir.
Yes, good. That's another important point for everybody to remember, that lambda are usually dimeric and kappa are usually monomeric. In this patient, they were kappa light chains, right? Uh, okay, and now coming back to the, you already have mentioned on this diagnosis slide, you mentioned the word crab.
Yes, sir.
Okay, so what does crab stand for, and what does slim crab stand for?
Sir, crab is, sir, hypercalcium if it is more than 11 gram per deciliter.
11 milligrams.
With creatine clearance of less than 40 ml per minute, or creatine more than 2 milligram.
Yeah.
Anemia if it is less than 10 gram or more than 2 gram per deciliter below the lower limit of normal, and if there is presence of any bony lesions. And sir, in slim, they include, sir, amount of plasma cells, sir. If it is more than 60 plasma cells, along with, sir, SFLC ratio, that is involved to uninvolved light chain, if it is more than 100, and MRI findings, if it is suggestive of lightly lesions, which is around 5 mm, we have, sir, myeloma
Yeah.
defined with biomarkers of myelin, sir.
Yeah, so these are all referred to also as myeloma defining events.
Events.
All right, that is the term that is used, MDE. And there is one other myeloma defining event which is not included in these. Just in case you happen to do a biopsy, supposing you've done a biopsy on such a patient without doing the serological testing that we've already discussed, and you find a cast nephropathy on that, sometimes that can be the first clue to a diagnosis of a monoclonal gammopathy, and that is also a myeloma defining event.
Yes, sir.
All right. So slim crab refers to these three myeloma defining events, and crab, of course, you have already clarified,
Yes, sir.
right? So this is another important thing that the residents should be aware of, right? We have just another 10 minutes to go before I hand over to Dr. Pankaj Malhotra for his presentation. So a few points that I'd like to take up. One, kidney damage in a monoclonal gammopathy. How do you classify it?
Classification, sir, if it is a paraprotein dependent or paraprotein independent. Sir, around paraprotein dependent, sir, 76% of cases, they are paraprotein dependent.
Yes.
But sir, light chain cast nephropathy, which accounts for around 33%, followed by sir, light chain deposition disease around 22%, and amyloidosis around 21%. Other glomerular diseases and tubulopathy, proximal tubulopathy can also be included, and along with that, sir, TMA can be possibility. While
Yes.
paraprotein independent, sir, 24% of cases we can see, sir. In that, sir, hypercalcemia, hyperuricemia, followed by drug-related toxicity like NSAIDs, ACE inhibitors, and sepsis and dehydration, sir. These are paraprotein independent causes for renal dysfunction.
Yeah, don't forget NSAID, which is often given for the bone pains that these patients have,
Yes, sir.
and also the bisphosphonates sometimes
Yes, sir.
can damage the kidney.
Yes, sir.
And rarely there is a third and yet another entity which is called plasma cell infiltration,
Yes, sir.
a
Plasma cell.
very rare entity, plasma cell infiltration of the kidneys.
Yes, sir.
Okay, so these are all paraprotein independent mechanisms of kidney injury in these patients. You have
Yes, sir.
already told us the breakup of the paraprotein dependent forms of kidney injury, right? Uh, yeah. So, if you have paraprotein independent injury versus paraprotein dependent, which one is has a better prognosis?
Sir, paraprotein independent, sir. If we there are most of the time, sir, they are reversible causes, sir. Hypercalcemia, hyperuricemia, and NSAID induced, followed by dehydration. So, yeah.
Yeah, yeah.
Yes, sir.
So, therefore, in those situations, recovery from the acute kidney injury can be expected,
Yes, sir.
right? Whereas in paraprotein dependent injury, recovery is not so common. In patients with a cast nephropathy, what percentage will recover some degree of renal function at least? May not be completely.
So around 40 to 40%.
They may recover, and the recovery may be only partial, and it may take a long period of time. It is not rapid recovery.
Yes, sir.
It's not rapid recovery, right? So those are again important things to remember. Uh, One more important point: how do you? What is the international staging of myeloma?
Sir, revised international staging, sir, RISS. Sir, it depends on, sir, presence of albumin, beta 2 microglobulin. In, sir, stage 1, sir, if albumin is more than 3.5 gram and beta 2 microglobulin, it is less than 3.5 milligram per liter with normal LDH and no high cytogenic, sir. It is stage 1, sir. And stage 3, sir, albumin less than 3.5, beta 2 microglobulin more than 3.5 milligram with high LDH and the presence of high cytokines. These are stage 3, sir. And in between, sir, it is stage 2, sir. So in stage 3, sir, beta 2 macron is more than 5.5, sir. I will correct.
Yeah, yeah. But you also need to, about beta 2 micro, you should also remember that if there is CKD or AKI, then the
Yes, sir.
beta 2 micro will be elevated. It will be very high, in fact.
Yes, sir.
So then it doesn't remain as useful
Yes,
for
sir.
the staging.
Yes, sir.
So because beta 2 microglobulin will be elevated in any patient with a reduced
Yes,
GFR,
yes, sir.
right? So that is as far as the international staging is concerned.
Can
Uh,
we now give it to, if you permit, after a minute after your
to
last comment?
Sure, sure, sure. Uh, so just my last few words. What is the survival like this patient? We have not been able to give her more than one course of chemotherapy because she developed recurrent infections, pneumonias, urinary tract infection. She was not able to tolerate chemotherapy. So we decided not to continue with chemotherapy for myeloma. And she's continuing on maintenance hemodialysis for the CKD. There has been no recovery of renal function. What is the survival of such patients on hemodialysis?
There is an increased risk of death, sir. They are said around 2.5 times higher risk of mortality in patient with multiple myeloma on dialysis than patient without multiple myeloma, sir.
Yes, so the 2-year mortality is said to be around 58%, and the high mortality is largely related to infections in these patients, right? And just one more point, what would you give for bone protection to these patients?
So denosumab every.
Yeah, in this patient, obviously the drug of choice would be denosumab, right? But if the patient were not in renal insufficiency, then what would you use?
Bisphosphonates, pamidronate.
Yeah, then in that case, pamidronate is considered the most safe bisphosphonate to use. You can give 30 to 60 milligrams once a month for protection against further bone resorption and hypercalcemia to these patients. So that is the other drug. Of course, rarely even pamidronate is known to cause focal segmental glomerulosclerosis. Need to bear that in mind. Of course, in a patient like this, the only drug you can consider for bone protection is denosumab.
Yes, sir.
Right. I think we've now reached 7:30, so I won't like to take more time on the clinical discussion, and I'd like now to request Dr. Pankaj Malhotra to take over and start his presentation. Dr. Pankaj, please.
Okay, thank you, sir. Am I audible?
Yeah.
Yes.
Clear.
And are my slides visible?
Yes.
Make it full screen, sir.
It's okay. Is it full screen now?
Yeah.
Yes, fine.
Okay. So good evening, everybody again. So thank you so much for this case and the discussion which we had on multiple myeloma and renal injury. It's a vast topic now. So what I am going to do is I'm going to discuss about the treatment of multiple myeloma in 2025. Obviously, there are many other things which can be discussed, like the diagnosis and the different imaging techniques and so many other things. We have not discussed about the MGRS also, amyloidosis. So I'm going to focus on the treatment part of it. So before 2000, as has already been discussed, myeloma was considered as incurable with poor prognosis. It is still considered as incurable, but even though the books mention it is incurable, but I can tell you with the available treatment now, at least 30% of patients I can say are cured of myeloma these days, even though the books will still mention incurable with poor prognosis. And before 2000, all the seniors will remember we had only very few medicines. Melphalan, prednisolone was the standard, or cyclophosphamide, vincristine, prednisolone, or a regimen which is called VAD, vincristine, adriamycin, and dexamethasone, which were used before 2000. And the life expectancy, as said, was between 2 to 3 years, and somebody with a renal failure on dialysis, not more than 1.5 to 2 years. And as Dr. Kher mentioned about one of our leaders, the Prime Minister, and the information is actually in public domain, so I can name VP Singh ji. And not only VP Singh ji, even Chandrasekhar also had multiple myeloma, and you can see they survived probably around 2.5 years to 3 years. And as the treatment advances took place, you also probably some of you may be knowing about Mulayam Singh Yadav ji, who survived for around 8 to 9 years. And some of you may also be knowing about the film actress Anupam Kher's wife, Kiran Kher, who is actually having myeloma for the last few years, and she is doing very well. She is doing all the shows. So you can see that overall from that time period, we have, we have multiple treatments. So what has happened between 2000 and 2025? So we have chemotherapy. So I'm discussing about the classes of drugs which we have to treat myeloma these days in 2025. We have drugs called immunomodulatory agents. We have antibodies. We have proteasome inhibitors. We have corticosteroids. We have cellular therapy. We have targeted therapy. We have antibody drug conjugates. We have drugs called bispecifics. We have drugs called selective inhibitor of nuclear transport. We have drugs called HDAC inhibitors. We have drugs called cell modes, and we have drugs called biological agents. So just to give a flavor of all the things. So in chemotherapy, we have old drugs like melphalan, cyclophosphamide, bendamustine, doxorubicin, cisplatin, vincristine, and very rarely, these drugs are used now. In the IMiDs, we have thalidomide, lenalidomide, and pomalidomide, and all the three drugs are available in India. In the proteasome inhibitor, we have bortezomib and carfilzomib. Ixazomib is an oral proteasome inhibitor, but it is not available in India. In corticosteroids, dexamethasone is the most commonly used drugs. Prednisolone also can be used. In the antibodies, we have daratumumab, elotuzumab, isatuximab, and daratumumab is available in India. In the cellular therapy, we have chimeric antigen receptor T cell therapy, and just a recent study last week, which was published, somebody relapsed refractory disease where the median survival is 2 months. 30% of them actually are cured. Single shot of CAR T cell therapy given 5 years ago, 30% of them have not required any therapy and they are cured. So you can, have this kind of thinking that the myeloma is going to be cured in future. In the cellular therapy, we also have autologous transplant and allogenic hematopoietic cell transplant. In the targeted therapy, we have a drug called venetoclax, which is BCL2 inhibitor and specifically given to 11-14 multiple myeloma. In the antibody drug conjugates, we have a drug called belantamab. Antibody drug conjugates are like, the missiles with a payload. So you have missiles which are called antibodies, but when you add a payload to the antibodies, these are called antibody drug conjugates, and belantamab is one of them. We have bispecific agents, which are called teclistamab and telcutamab, which are, teclistamab is available in India and one of the wonderful drug, I would say, for use in myeloma. They just work like a CAR T cell therapy, and we have been using teclistamab, very wonderful drug, but costly. Selective inhibitor of nuclear transplant, selinexor, is not available in India, but we have done the trials. Again, a wonderful drug, once a week oral therapy. HDAC inhibitors, penobinostat, has been taken off the market because they were quite weak agents. In the biological agents, we had interferons, which are now very, very rarely used in myeloma. And cell mode therapy are iberdomide and mezidomide. Both of these drugs right now are not available in India, but they are wonderful drugs. We are doing this trial of both of these drugs. So these are the class of drugs which we have to treat myeloma these days. And the beautiful thing about the treatment is that you can combine most of these drugs with each other. So you can make different combination of these drugs because each has a different mechanism of action. So the treatment of myeloma these days is now changed. It is now converted into 3 phases of treatment called induction treatment, consolidation treatment, and maintenance treatment. So we are going to discuss about what is the induction treatment, what is consolidation, what is maintenance treatment. So the aim of the induction therapy is that you want to achieve the best response in myeloma, because if you achieve the response, this will lead to prolongation of survival. So before 2000, we had only a partial response or a very good partial response. So that's why, we used to stop the medicine for, given for 4 months, 6 months, and then stop the therapy. And at relapse, we used to give again. But these days, we talk of a best response, and I will discuss in my subsequent slide, the best response these days we called as MRD negative, minimal residual disease, or measurable residual disease negative status of the patients. So these were the uniform response criteria which were given in 2006. Partial response, very good partial response, complete remission or a complete response, and a stringent complete response. So these were given in 2006, and now these have been revised in 2016, and I will discuss in subsequent slides. So how do you choose your induction therapy? Whether you give 2 drugs, 3 drugs, or 4 drugs. So there are different trials, and when you give 2 drugs, this is called doublet. When you give 3 drugs, this is called triplet. So in 2010, this study was published, where bortezomib with thalidomide plus dexamethasone, what we call as VTD regimen, was compared with 2 drugs, thalidomide plus dexamethasone. So when thalidomide became available in 2000 or so, we were all using thalidomide and dexamethasone, a doublet, for many, many years. And once the bortezomib became available, then we started using bortezomib also. So this trial compared 2 drugs versus 3 drugs. And the complete response was achieved in 31% of patients in the triplet regimen versus 11% in the doublet regimen. So this was published in 2010. So that time, people said a triplet is the standard of therapy because the chances of achievement of complete response are better when you're using 3 drugs. And if you achieve a complete response, your survival is better. Then, people started using triple drug, and this is a trial which is called SWOG S0777 trial, where they use bortezomib with lenalidomide and dexamethasone, and versus lenalidomide and dexamethasone regimen. Again, if you focus on the overall response rates, 81% in patients who are given triplet regimen, which is called as VRD regimen. And I would be using this term VRD regimen in my subsequent slides. So VRD is better than doublet again. Then people said, okay, does it matter whether you are using 3 drugs, does it matter whether you want to use lenalidomide or you want to use cyclophosphamide, whether that makes a difference? So there is a trial comparing a regimen called VCD, bortezomib, cyclophosphamide, dexamethasone. This is also called CyBORD regimen, versus the bortezomib, thalidomide, dexamethasone, so VTD regimen. So comparing the VCD or CyBORD regimen with VTD regimen, and again here showed that our response rates were better if you use a VTD regimen over a VCD regimen. Okay, so which basically means in terms of response rate, if you want the best response, the VRD regimen, that means bortezomib, lenalidomide, dexamethasone, is better than bortezomib, thalidomide, dexamethasone, which is better than bortezomib, cyclophosphamide, dexamethasone, which is better than thalidomide, dexamethasone regimen. Okay. So patient receiving the 3 drug combinations have higher chances of achieving a biochemical remission and stringent complete response, which will obviously lead to prolonged survival of these patients. And if you use the VRD regimen, the median survival of these patients is close to 3 to 4 years. This is median survival, and I hope most of you understand what we mean by a median survival of the patients. So before 2000, we were very happy achieving a partial response. In 2000, by 2010, we were very happy achieving a complete response, and then we wanted a stringent complete response. So we were actually going from good to better to best. Now, I mentioned about a drug called daratumumab, which is an anti-CD38 antibody, daratumumab. It's like, you must have heard about in lymphoma, we use CHOP regimen, and then from 2006-7 onwards, we are using R-CHOP regimen. Rituximab is an antibody. So here, and rituximab is anti-CD20 antibody. So DARA is anti-CD38 antibody, and CD38 is a plasma cell marker. So people said, if you add daratumumab induction, what will happen? So this is a regimen, this is a trial which is called Cassiopeia trial, where they added a daratumumab with bortezomib, thalidomide, and dexamethasone, and they showed that a stringent complete response and a complete response were better when you add a daratumumab. And I discuss about the MRD negative rates. The MRD negative rates were better when you're using daratumumab in the induction therapy. And as I said, if you are achieving a good MRD negative response rates, your survival is better. And then obviously the next choice is people were using VRD regimen. So what happens to the daratumumab adding to the VRD regimen? This is called a Griffin trial, where again the MRD negativity rates were close to 50% or so in these patients, as compared to if you are using only the triplet regimen of RVD or VRD regimen. So DARA RVD improves stringent complete response rate and MRD negativity versus the RVD or VRD, both of which deepened over time. And there are not many side effects. So a response criteria was added in 2016 or 17, which is called MRD, which should be negative by flow or by NGS. By flow, it is easily available in most of the laboratories in India. So why we are talking about the MRD? So this is, when we talk about the plasma cells, so this is what the number of plasma cells are when we talk of a stringent CR. So even then, you can see that the number of plasma cells are still very high. And what we are talking about is the MRD. And when MRD is undetectable, we are talking of a operational cure of this patient, which I'm talking, can happen currently in 30 to 40% of patients. So we are talking of cure of myeloma these days and for a newly diagnosed patients. So addition of DARA in VTD or VRD induction lead to increase in the MRD negative rates, which obviously will lead to increase the survival. And the median survival of DARA VRD regimen is 56 months. That means if you're diagnosing the patient today, a newly diagnosed myeloma, and if you're giving DARA VRD regimen, so you can expect approximately median survival of 5 years. That means no, he may not, have a relapse in the next 5 years or so. So one of the question is daratumumab or anti-CD38 antibody is quite costly. For an average Indian adult, the cost would be approximately 1.5 lakhs. And if you want to give 16 cycles of daratumumab, so that would come to around 20-25 lakhs or so. So many times, the question comes whether you want to use upfront or at the time of relapse. And this is a simple question which I ask to the patient or to yourself. If the patient relapses after 4 years, 5 years, or 6 years, whether you would give DARA to the patient at that particular time. If you are going to prescribe daratumumab at the time of relapse, then it is better to use DARA upfront than at the time of relapse, because the relapse disease is always high risk. That means once the patient relapses, then the chances of whatever curability are now not there. So the chances of curability are only if you are using these very good therapies in the upfront setting. So don't consider myeloma as that this is a disease of remission relapses. This is a disease where you should consider as, in some patients as a curable disease. One of the other question which comes is the proteasome inhibitor carfilzomib is available in India. So whether to use carfilzomib or a bortezomib. So again, people have compared this. This is called a 40 trial where carfilzomib is cyclophosphamide and a combination, a complex kind of a trial. But again, this showed that if you use carfilzomib, these patients will do better. But the risks of carfilzomib in our setting are a little bit high, and it is an IV infusion. And one of the side effects which we have seen with carfilzomib is carfilzomib-induced thrombotic microangiopathy in some of our patients. So we are not very comfortable in using carfilzomib in the upfront setting. So I was talking about the MRD negative rates. So these are the rough MRD negative rates in different trials. So in the DARA, KRD, carfilzomib, Dexa, the MRD negative rates are close to 96% or so. So the summary of induction therapy, VRD, the cost is approximately 4,000 rupees per month. Bortezomib is available at 400 rupees one injection, a 2 milligram injection. So this is around 4,000 per month. You can use VCD or Cybod-D in case of renal failure, because lenalidomide has a renal excretion and it is very difficult to check the creatinine clearance each time before you modify the dose of lenalidomide. So you can use lenalidomide, but at a lower dose when the patient has renal failure. So you can use Cybod-D or VCD in case of renal failure at the time of diagnosis. And once the renal failure recovers, you can upgrade to VRD regimens. You can add daratumumab in the induction therapy if the patient is affordable. A carfilzomib-based regimen you can use in very high-risk young patients and if patient is affordable. So the duration of induction therapy, this is again very important, how long to give. We divide these patients, whether the patients can afford an autologous transplant or not. And autologous transplant is considered as consolidation therapy. So what we do is that we give this therapy for 4 cycles to 6 cycles to patients who are transplant eligible. If they are not going for transplant, we can continue up to 9 cycles until transplant, because as you continue the therapy, these patients, they deepen their response. So in the transplant ineligible, generally you continue the regimen till 9 to 12 cycles. That means almost an year or maybe more than an year of therapy. The other treatment regimens in transplant ineligible patients or elderly patients are, you can give daratumumab with lenalidomide and dexamethasone. And again, this regimen is considered as very good. This is a Maya trial. And there is L-Sion trial. You can combine daratumumab with melphalan, prednisolone, and thalidomide. Again, this has led to increase in the progression-free survival as well as overall survival. So in the induction therapy, transplant eligible patient, VRD, Dara-VRD, KRD, ineligible patients, you can use VRD light regimen where we can reduce the dose of lenalidomide, or daratumumab, lenalidomide, dexamethasone regimen. So after the induction therapy, the aim of which is to achieve the best response. The most of the patients, after 6 cycles or 8 cycles, they achieve a stringent complete response, and some achieve an MRD negative status also. And then you consolidate. So for transplant eligible patient, which is, somebody who is otherwise fit and healthy. So not necessarily the age. The general cutoff age is taken as 65 years in India, but in US the cutoff is 78 years or 79 years. So here in India also we say if somebody is 70 years but otherwise fit, he is a candidate for going for an autologous transplant. The purpose of consolidation therapy is to improve upon the response which you have already achieved with an induction therapy, or you deepen that response. And this is the different trials, which it is a French study, lenalidomide, botiz, dexamethasone with transplantation for myeloma. So VRD followed by transplantation, where they compared continuation of VRD versus doing a transplant. And they found that the patients who achieved, who are only on VRD regimen or RVD regimen versus patients who got a transplant, they had a better response rates and better MRD negative rates. So 79% versus 65%. Another trial looking at the triple therapy, transplantation and maintenance until progression. Again, here the ones patients who had undergone transplant, their median progression-free survival was 67 months as compared to 46 months who were not transplanted. This is one of our paper looking at the stem cell transplantation in multiple myeloma, very much alive and kicking. And the PFS rates, in different, these are the different series from India. And in PGI series, we have approximately 75% of patients who are surviving more than 6 years or so. So when you consolidate, you can consolidate with melphalan, 140-200 milligram per meter square. For transplant ineligible patient, you continue the therapy. You don't stop the therapy. So the same therapy, when you continue, this is called a consolidation therapy in these patients. This is just American Society of Transplantation Clinical Practice recommendation for transplantation and cellular therapy. So after the induction consolidation, we come to the maintenance therapy. The purpose of maintenance therapy is whatever response which you have achieved, you maintain that response. And sometimes even if you have not achieved MRD negative status, you give the maintenance therapy and you achieve an MRD negative response in those patients. So this is the trials which are showing the effect of maintenance therapy. And you can show the PFS as well as the benefit in OS, and significantly improve overall survival also. So CalGB, another trial, phase 3 trial looking at the same thing, both the PFS and the OS are better. So in the end, I would share some practice points to consider all newly diagnosed patients transplant eligible of age less than 70 years. As I already said, if the otherwise patient is fit enough, they can undergo a transplant. Consider VRD or Dara-VRD as induction therapy because this has shown the best response rates. Reassess the patient every month for transplant eligibility. So in India, what happens is once you talk of a transplant, people think of some kind of a surgery. It is not a surgery. It is a process which goes on for 15 to 20 days. So, many times, after 3rd month or 4th month, patient agree for a transplant. So once the patient, transplant eligible, he agrees. If he achieves a very good partial response, mostly, after 4 to 6 cycles, you can take up this patient for auto transplant as consolidation. Patients who are ineligible or unwilling for transplant continue the induction therapy until patient achieved a maximum response or stringent complete response. Generally takes 6 to 9 months. But the therapy can be continued for 12 to 15 months if the patient is tolerating it to deepen those responses. Dexamethasone, very interestingly, can be omitted or dose reduced after 4 to 6 cycles, because multiple studies have shown that even though dexamethasone is one of the best drug for myeloma, but after 4 to 6 cycles, its effectiveness reduces and it only leads to infections. So once the patient achieved a stringent complete response, which means serum protein electrophoresis, immunofixation, and serum free light chain normalize. And one of the question in the discussion was that all these tests are very costly. So I would like to share one thing, that if you write these tests if you are getting from the private lab as SPEP, IFE, and serum free light chain, they would cost something like 16,000. But if you write myeloma panel, so if you write panel, they will do all these tests plus immunoglobulin levels plus beta 2 microglobulin in 5,500 rupees. So this is a trick by the private laboratories, both the common laboratories, Lal laboratories and relegate laboratories. They can do, when you write myeloma profile, they will do these tests in 5,500 rupees. Whereas if you write separately or just write free light chain, they will do in 6,000, 7,000 rupees. And overall, they will cost 16, 17,000 rupees. So this is one of the point which I wanted to share, when we say that these tests are very costly. Okay, so we need to, do these tests to look at whether the patient has achieved a stringent complete response or not. Now, before, stopping the induction therapy, you have to assess the MRD status of the patient. Please don't stop the therapy if the MBET has become negative or immunofixation has become negative or light chains have become normal. We have to assess an MRD negative status, and MRD negative status is seen by a bone marrow examination, by a flow cytometry, and doing a PET CT. So PET CT again plays a very important role, and I will discuss in question which was asked, what is the best imaging modality for the myeloma? I would discuss in the next slide. So we do the bone marrow examination for MRD as well as PET CT. If both are normal, then we say patient has achieved an MRD negative status. And then you can put this patient on maintenance therapy, len for a standard risk and doublet, lenalidomide and bortezomib for high risk patient. And in any of the test is positive, let's say bone marrow test is still showing, plasma cells on flow cytometry, then you continue the induction therapy. Please don't stop the therapy. That is one of the commonest mistake which we have seen. People give 6 cycles, 4 cycles, 9 cycles, and then they stop the therapy. Please don't stop the therapy. This is called a continuation therapy. And discuss the auto transplant with eligible patient. The practice point 4, patient continue the same therapy, bortezomib and lenalidomide for 2 to 3 years. As I said before, this is called a continuous therapy, and this has been found to be improvement in the overall survival of the patient. Auto transplant patients have high chances of achieving an MRD negative status and thus going on to the maintenance therapy. And maintenance therapy is generally continued indefinitely as long as the patient remains in MRD negative status. But this is an area which is developing very fast. So every year you have to do an MRD status. That means you have to do bone marrow every year and PET CT every year. And if MRD is patient is MRD negative in both bone marrow as well as in imaging, you can consider stopping the therapy after 4 to 5 years of treatment. That means this patient is probably cured of myeloma. So 20 to 30%, but I'm in future with the CAR T cell therapy and with bispecifics, I think these figures are going to be around 50% or so. What I have not discussed is newer diagnostic criteria for multiple myeloma, but this has been discussed in the during the case discussion, the myeloma defining event. These were revised in 2014, and the reason why the smoldering myeloma patients, which the previously considered smoldering myeloma patients, now considered as myeloma, was because we have a lot of drugs now treat myeloma. The role of cytogenetics I have not discussed because this is very important to discuss whether the patient has a high risk or a standard risk multiple myeloma. Yes, the imaging. Now, the skeletal survey is now not done. It is not kind of an indicated, I would say, because the best best image to do is the low dose whole body CT scan, which can be done just in 2 minutes, and you get a full body picture. If you ask for a skeletal survey, the patient would be, will be in the radiology for 3 hours, 4 hours, going to the different rooms for the imaging. If you do a low dose whole body CT scan, that has a better pickup power. And why we say so is because skeletal survey would pick up the myeloma bone disease only when there is 80% bone damage. We want to pick up the early thing. So that is a CT scan of the and now most centers are doing the low dose whole body CT scan. Now about the PET CT and MRI. MRI is definitely a better modality, but there is some catch over here. Now, what you need to do is MRI, you need to do a diffusion weighted MRI, not a simple MRI. The problem is the diffusion weighted MRI depends on the software of the MRI machine. And in India, unfortunately, most centers do not have that software. In PGI, we have the latest MRI machine and we have that software. We are taking this, doing this kind of a study, looking at the correlation of PET CT with MRI. But the diffusion weighted MRI takes, at least hour and a half to do that kind of a full image. So it is, little cumbersome for patients, especially, patients who come with back pain and sometimes they are not able to lie down for so long. So most hematologists or oncologists these days do a PET CT scan, which is easily available and can be done. But the advantage of PET CT is that you pick up the extramedullary disease. Now, the extramedullary disease, if the patient has, that gives a poor prognosis to the patient, and hence, your treatment regimen may change. So, out of these 3 drugs, what we do in our clinic is low dose whole body CT scan is done within a day. So, we get a low dose whole body CT scan and then we get a PET CT. MRI we are only doing as a part of research projects. I have not discussed about the infection prophylaxis. So, the case which is discussed in this forum is patient was getting infection. So one of the things which we have to do in all these patients is we need to vaccinate them. So we give both Shingrix, which is a herpes zoster prophylaxis, as well as Pneumovac and PCV13. We first give PCV13 followed by PCV23. And infection is a very common problem. And if the patient is developing recurrent infections, then sometimes you have to supplement IVIG to these patients. Supportive care, Zoledonic and Denosumab. Zoledonic has been found to be better than Pemidronate in different studies. This is MRC trial where they have shown Zoledonic has actually led to some improvement in overall survival also. Denosumab and Zoledonic are almost equal. Denosumab you use when there is a renal failure, but most Denosumab is costly. So what happens is Ibandonate is one drug which is you can use in patients with renal failure also. Even though Ibandonate is not approved for multiple myeloma. So what we do in our clinic is we either give Pemidronate in presence of renal failure, either 30 milligram or 60 milligram, or we give 2 milligram of Zoledonic acid. So that sometimes, we make an arrangement for patients who cannot afford Denosumab, which is costly. I have not discussed about the treatment of relapse, whether you treat at a biochemical relapse or at a clinical relapse, and what is the role of repeat bone marrow cytogenetics, dialysis, plasmapheresis. We have not discussed about the plasmapheresis. Again, it is a long discussion. I favor a plasmapheresis in a patient who has a cast nephropathy. Renal transplant in patients of myeloma with chronic renal failure, we have not discussed. Again, that is a big topic. So the summary of treatment, the newly diagnosed multiple myeloma patient, physically fit with acceptable comorbidities, transplant eligible and ineligible. This is how we divide the patients, and we do a risk stratification based on ISS or revised ISS, cytogenetics, renal failure. And in India, I feel finances are very, very important. So based on finances also, we decide about the treatment. So transplant eligible patient, 4 to 6 cycles of 3 to 4 drug combination, achieve a PR, VGPR, CR, auto transplant and maintenance therapy. Ineligible patient, 9 to 12 or 12 cycles. So this is some ambiguity. And as I said, the aim is to achieve an MRD negative status and then followed by maintenance therapy. And with this kind of a therapy, the median response duration is close to 4 to 5 years. And then, a patient with high risk definitely relapse response. The median survival these days is somebody is newly diagnosed patients and average affordability, I would say more than 10 years, he should survive. Somebody who is fully affordable, I would say probably more than 15 to 20 years. As mentioned in the beginning, we have a society called IMAGE, Indian Myeloma Academic Group, and we are affiliated with the International Myeloma Society, and we hold this conference every year. Anybody who is interested in India in myeloma, they can. The next conference is in Kochi in the second week of January. This is the 8th annual conference of our group. Yeah. And we have a PJ textbook of laboratory and clinical hematology. Somebody who is interested in hematology, or you can pass the message to the different residents who are interested. This is written by all the PJ alumni, and this is in 3 volumes, 11 kg in weight, close to 209 chapters, 107 authors. Yeah, with that, thank you very much for your kind attention. Happy to take questions.
Thank you. Thank you, Dr. Pankaj. That was remarkable and tremendous, because you covered a lot of things. But my one question is, because kidney transplantation, when would you do it? Just a question, at what stage would you consider kidney transplantation? Many patients are on dialysis when they are treated, and they would feel, if they have achieved a reasonable kind of a remission with MRD negative disease, at what stage would you think they would be suitable for a kidney transplantation?
Yeah,
2
I
years
would
MRD negative.
Yeah, I would like to add to that question. Would you always advise a bone marrow transplant before kidney transplant, or can you do a kidney transplant without that?
So again, it depends on the MRD negative status. As I said, at least 2 years patient should be in MRD negative status before you do a kidney transplant. So if you do an autologous bone marrow transplant, the chances of achieving an MRD negative status are very high. So that's why generally we recommend doing a bone marrow transplant before doing a kidney transplant. But let's say somebody who has achieved a standard risk and he has received a very good drugs and he has achieved an MRD negative status, even if he has not done a transplant, and if he's in MRD negative status for 2 years, we can take up that patient for a kidney transplant.
Okay.
Actually, I had a patient who had multiple myeloma many years back, and then he underwent a bone marrow transplant in US, came back in remission, remained in remission for a reasonable time, and we did transplant him in 2006. His father being the donor, his father died very recently. Now he was 90 years old, and when he donated, he was 75 years of age. So we did a transplant, and this person is doing extremely well and has remained in remission now almost about 17 years after the bone marrow and the kidney transplantation. So extremely good kind of a thing. But I would guess that probably this is not the usual outcome. What would be the outcome of patients who have had bone marrow transplants and renal transplants? This patient had transplant many years back. I would think that current therapies probably should provide much better outcomes in these kind of patients. Pankaj, what's your take on that?
So sir, the newer drugs are, very effective, but they are quite costly. Bispecifics, I talked about teclistamab, one injection is costing around 2 lakh rupees, and you have to give, every weekly and continuously, weekly or, once in 2 weeks time. So, and it is a continuation therapy. So they are very effective, but, quite costly. CAR T cell therapy, we are doing CAR T cell therapy trial for multiple myeloma. And hopefully the CAR T cell for myeloma should come in India next year. The Origin company is going to launch. They have already done phase 1 trial. The phase 2 trial is ongoing. So once the CAR T cell therapy comes, it is going to cost close to 40 lakhs or so. But it is a one-time kind of a treatment. So I would say in future, if you ask me to hypothesize, I would say Somebody who wants a kidney transplant, you do a CAR T cell therapy, and then you can go for a kidney transplant. As I mentioned, the CAR T cell therapy, which is available in US for a relapsed refractory multiple myeloma patient, where we talk of median survival of only 2 to 3 months. There, when they used Cilta-cel, which is a CAR T cell therapy, 30% of patients are in remission, no therapy at all, single time therapy 5 years ago, and 30% of patients are kind of a cured of myeloma. So you can imagine the effectiveness of newer therapies which are coming up in the field of myeloma.
I think wonderful. I think mesmerizing. I thank you profusely, Professor Pankaj, for a masterly lecture. I think everybody has benefited. Can I request Professor Ellen Almeida? Is he around, Professor
Yeah,
Ellen?
yeah, I am.
Please, yeah.
Well, it's been a really mesmerizing session, starting with a case presented by Shrinath, and then Vinay taking us through the entire gamut of how the patients present, and in fact talked about the various hypercalcemia, undiagnosed renal failures, especially in the elderly, and then going on through various aspects of how you evaluate the patient, what may be the investigative findings, and going on to various other practice points and points which covered the diagnosis or what would lead you to a proper diagnosis, whether it be radiological or the other biochemical indicators, and going on to the complications which are seen in patients. There was a couple of things which I just made note of. One was they also talk about roller formation, but I don't know how many people now look at the peripheral smear to look at roller formation and pointing to the diagnosis. Second thing is you brought up a point about sepsis. The part about altered sensorium, and I think Pankaj brought it out that the sepsis is a component which would result in altered sensorium. Also, third point which came up was the point about uh, MRI, and there was a question about a non-contrast MRI versus a gadolinium-based MRI. And I think that the KDIGO now supports even the use of the category 2 GADO compounds for if you require. Of course, Pankaj did mention to us that a low whole body CT scan would be good enough to pick up the light lesions. But I think these points, considering that we are already overshot at time, these points would be what I would like to draw attention. Like, of course, excellent way that Vinay went through the case.
Thank you very much, Professor Allen. I think I was impressed with the two practical aspect what Dr. Pankaj said, the low dose CT scan, which I think can be done in no time and pretty reasonable, doesn't require extra software. And second, he was also a tricky point that you do a myeloma profile rather than asking for all the three. That's also a pretty practical point. I think excellent discussion. I think before I'll hand over to Professor Kher for final comment and conclusion, I thank Professor Sakhuja, my teacher, as for masterly case taking as usual. And over 100 students always come if he's around. And I hand over to Professor Kher.
I think what you said is perfect. That Vinay discussed it in a masterly fashion, as usual, as was expected also. And the only point I would make is that I think as examiners also we need to also grow. Like Pankaj said, that probably currently low dose CT scan, whole body CT scan would be the thing that would be done. And I think we need to forget about the old things that we were doing. Bench zone proteins, I don't think anybody is going to do these days because you have much better tests available. So probably impinging on the students, they may historically this may be all right, but I think probably if they don't know it, I don't think I would penalize them because they don't do it on a day-to-day basis. When we were students, we used to do it uh, uh, day in and day out, and that's how we would make it. But then most sensitive tests were not available at that point of time. So I think from that perspective, I think what Pankaj said is good methods of diagnosis also. I'm sure genetics and other things are also coming up, which would help. And I feel that I've gained tremendously during this session, and a lot of new knowledge also imbued by Dr. Pankaj. And I'm glad that being a PGI alumni, 11 kg size books written by and authored by a friend of mine also, and Dr. Subhash Varma, who was our colleague during our time. And I could see his name as well. Pankaj is much younger, but it was such a pleasure to listen to Pankaj and the whole team. I must congratulate all of you for doing such a wonderful job. Thank you very much. And I think I must thank Steadfast for providing us this technical support and the logistic support for doing these classes. And I'm sure everyone who attended this session today would feel extremely sort of knowledgeable about multiple myeloma, many new things which came up for the discussion and for knowledge. So thank you very much. Thank you, everybody. I, on behalf of Dr. Varma, would like to thank both Dr. Vinay Sakhuja. The presenter was exceptional, very good, he answered all the questions so well. And I must thank Dr. Almeida and Pankaj for delivering such a report. Thank you and goodbye from every one of us. And thank you very much.
Thank you. Thank you.
Thank you. Thank you very much. Good night.
You.
Thank you.
Thank you. Thank you. Good night.
Thank you.